Thanks, Amy. Good afternoon, and thank you all for joining us for our 2026 Workforce Collaborative Training Series. Today, we're very excited to have Dede Berdine, Hope of Erie County Primary Care Research Institute and University at Buffalo, with us for trauma-informed practice in the Brief Trauma Questionnaire. A few quick reminders before we start. At the end of this session, we will be asking everyone to complete a very brief evaluation. Please take a moment to fill us out so we can continue to improve our training series. Our July session will be July 28th from 12 to 1 p.m., Building Brain Healthy Habits with Tanya Hernandez from the Alzheimer's Association. We are always looking for new presenters, especially as we fill our calendar for our second half of 2026. We are interested in hearing what topics and speakers you would like to hear from. So if you're interested in doing a 1-hour presentation, or if you're interested in a particular topic, you can indicate that on your evaluation, or you can contact Amy at amy.rockwood@erie.gov. Tomorrow, June 24th, the Anti-Stigma Coalition is hosting a Facebook Live, Healing Beyond Trauma, Understanding PTSD and Overcoming Stigma, which will be from 12 to 1. A great tie-in to what we're talking about today. So we will post the link to that in the chat at the end of our session, or you can follow the Anti-Stigma Coalition on Facebook and they will have the link to that live there as well. Our training today is being recorded. Both the slides and recording will be posted to our website within the next few days. Just a reminder, the presentations and recordings for our past offerings are posted on our website as well. We have 5 years worth of amazing trainings. So if you have new staff, have them check it out. Or if you're looking for information on a particular topic, that's probably there too. Everyone is muted. So if you have questions, please put them in the chat. I'll be monitoring the chat, and Dede has saved time at the end to answer some questions for us. Thank you all for joining us today. And I'd now like to introduce Dede Berdine. Thank you so much for joining us. It's all yours.
Hello, everyone, and welcome. So as Kathleen mentioned, I'm Dede Berdine. I'm with Hope of Erie County, which is a transitional case management, evidence-based case management program. And we work with people who use drugs and are in the criminal legal system. We are administered by Primary Care Research Institute here at UB. And along with our lovely partners at the Erie County Department of Mental Health, we applied for funding from the Bureau of Justice Assistance. And the goal of this grant is to screen for and address the issue of unresolved trauma, particularly for those with substance use disorders and mental health concerns in drug treatment courts. On our agenda today, we will discuss the purpose and scope of the Brief Trauma Questionnaire, or the BTQ, as I will refer to it from now on. We're going to talk about the types of trauma captured by the BTQ. We're going to look at its trauma-informed framework. We're going to discuss trauma-informed administration of the BTQ. We're going to look at how BTQ responses can inform decision-making. Then we'll discuss the clinical and ethical considerations of administering the BTQ. And then if we have time, I also have 2 case reviews that we can go over so I can demonstrate how we use the BTQ and what the results were. And we also have a discussion section if you guys don't have questions. And I have a lot of the Hope team on today, so we may refer to them as they are the experts who administer this tool for some of their insights and experiences. Purpose and scope. So first, a little history. The BTQ was created by a researcher and clinical psychologist named Paula Schnurr way back when in 1999. Paula is the executive director at the VA National Center for PTSD. So she's a key figure in shaping how we measure and understand trauma in clinical and research settings. She wanted to create a tool that could quickly and reliably identify trauma exposure without doing a full interview or a full assessment. Excuse me. So what's the purpose? What does it do? So the BTQ identifies lifetime exposure to traumatic events by using a brief structured set of questions. And this tool actually focuses on exposure, not diagnosis or symptoms. So it works to serve as an entry point for further screening and decision making. What does the BTQ not do? It doesn't require details or a narrative. It's not an interview. It doesn't ask for stories or descriptions, and it avoids deep probing to protect the emotional safety of the participant. And the BTQ does not replace clinical judgment. It's a starting point. It's not the full picture, and results, if there's positive for trauma, should be followed up or referred to for clinical conversation and additional screening. So I know this is kind of hard to see, so I'm going to read the items for you, but I wanted you to see what the tool looks like. So there are 4 columns. In the first column are the 10 events that we ask the clients about. The second column asks yes or no, has this ever happened to you? The third column asks, in the event it happened, did you think your life was in danger or you might be seriously injured? And then the fourth column is, if the event happened, were you seriously injured? So going through and reading these, the first one is, have you ever served in a war zone, or have you served in a non-combat job that exposed you to war-related casualties, for example, as a medic or on Graves registration duty, yes or no? And then if you answered yes, you go to the next column that says, if the event happened, did you think your life was in danger or that you might be seriously injured? And then the next column says, if the event happened, were you seriously injured? The second item is, have you ever been in a serious car accident or serious accident at work or somewhere else? Have you ever been in a major natural disaster or technological disaster, such as fire, tornado, hurricane, flood, earthquake, or chemical spill? Number 4 is, have you ever had a life-threatening illness such as cancer, a heart attack, leukemia, AIDS, MS, etc.? Number 5 is, before the age of 18, were you ever physically punished or beaten by a parent, caretaker, or teacher so that you were very frightened, or you thought you would be injured, or you received bruises, cuts, welts, lumps, or other injuries? Number 6, not including anything identified above, have you ever been attacked, beaten, or mugged by anyone, including family, friends, or strangers? Number 7 is, has anyone ever made or pressured you into having some type of unwanted sexual contact? Number 8 is, have you ever been in any other situation in which you were seriously injured, or you've been in any other situation in which you feared you might be seriously injured or killed? Number 9 is, has a close family member or friend died violently, for example, in a serious car crash, mugging, or attack? And number 10 is, have you ever witnessed a situation in which someone was seriously injured or killed, or have you ever witnessed a situation in which you feared somebody would be seriously injured or killed? So the third and fourth columns are what make this tool clinically meaningful, because they tell us whether the experience meets the threshold for trauma, not just whether something happened. So again, column 2 identifies the exposure, column 3 assesses the perceived threat, and column 4 assesses the actual physical harm. So on this slide, I wanted to show you how it differs from a diagnostic assessment. So it's trauma exposure screening versus a diagnostic assessment. So exposure screening, or the BTQ, we ask what happened. In a diagnostic assessment, we ask, how is this affecting you now? The BTQ identifies exposure, where a diagnostic assessment evaluates symptoms. The BTQ is brief with just yes, no answers, and a diagnostic assessment is in depth. The BTQ doesn't assess for symptoms and doesn't diagnose, where the diagnostic assessment can be seen in the name, determines diagnosis. And the BTQ exposure screening guides planning and engagement, where a diagnostic assessment guides treatment. And I just want to say that when we originally proposed this grant, we actually proposed we would be using a trauma screen questionnaire to screen for trauma. But once we reviewed it, we realized it was a PTSD symptom screen, and that really wasn't appropriate for what we wanted to do because the BTQ is better for trauma, in my opinion, for trauma-informed care planning. So we use the BTQ results to shape, support, not to diagnose. So who is this for? Who uses a BTQ? So here are some examples. So in behavioral health, we can use it to inform treatment planning. In the courts, it can improve compliance and outcomes and inform realistic expectations. In a community supervision role, it can help explain non-compliance and engagement challenges. For law enforcement, it can help support safer and more informed interaction. For social services and/or children's services, it can help us understand family instability and risk. And for homeless services, it could help connect trauma to housing instability. It might give us some answers and help us guide treatment a little bit better. So the BTQ is a trauma-informed framework. And the question is, why it matters? Why does trauma-informed screening matter? Well, trauma is very common in the populations we serve. Trauma often goes undisclosed unless it is asked about. And trauma-informed screening helps us respond appropriately. And the goal is not to diagnose in the moment. It's to identify the trauma exposure early enough so that we can to guide a safer, more appropriate next steps. And if we don't ask about trauma safely, we risk misunderstanding the person and missing what they actually need. So using the SAMHSA's core principles of trauma-informed care, the first core principle is safety, and that tells us that physical and emotional safety are prioritized. People should feel secure, respected, and not threatened by the environment or process. And predictability and calm interactions help support engagement. With the BTQ, it's structured to minimize activation and overwhelm. So there's no requirements for detailed recounting, and it can be paused or stopped at any time. And this matters because, as we know, early service and other environments can already be stressful. We work in drug treatment courts, and we find that when our participants are new to the court, they get kind of overwhelmed with all the information that's coming at them, and that can be stressful. So we often don't give them the BTQ right away until they've kind of stabilized a little bit and feel a little bit more comfortable with us. So the BTQ does avoid adding emotional risk during the assessment, but you do need to make sure that they're in the right place to do it, and we'll talk about that. SAMHSA's core principle of trustworthiness and transparency tells us that we should be clear about what is happening and why with our clients, that we communicate openly about expectations, decisions, and next steps, and that consistency and honesty help build and maintain trust. So with the BTQ, how the tool is introduced builds the trust. So we want to give them a clear explanation of the purpose of the BTQ, honest about how the information will be used. We don't want any hidden agenda. And this matters especially where trust may already be low. Again, in my court example, clients don't come to court trusting the judge and trusting everybody in the courtroom. And while we're not part of the court, we're a service of the court, we sometimes struggle with getting them to trust us as well. For the core principle of peer support, SAMHSA tells us, and we know this from experience, that peer support and mutual self-help are key vehicles for establishing safety and hope. Lived experience can strengthen trust, connection, and engagement, and peer relationships can reduce isolation and support recovery and healing. So with regard to the BTQ, peers can support the process by helping clients feel safer, more understood, and more willing to stay engaged. In some programs, trained peers may help administer or support the screening process. And in my program, I have 4 peers, and they actually do the BTQ. But if they're not actually administering the BTQ, they can still be nearby physically or just at the ready before, during, and after the survey. SAMHSA's core principle of collaboration and mutuality. We work with people, not on people. We work to reduce power differences, and we want to emphasize partnership and shared decision-making. We want to be as person-centered as possible. So for the BTQ, it can be introduced as a shared process, not an interrogation. You're doing this together, and we can explain it's a tool to help the team and the client better understand what supports may be helpful, rather than feeling like something is being done to the client. We know it allows the person to participate with choice and control because they can end it at any time. They can skip questions, and it shifts the staff role from authority to partnership. Hopefully that's the goal. So saying something like, given what you've been through, what kind of support might help? We want to include them in the decision making. Nothing about us without us. Core principle of empowerment, voice, and choice says people should have a say in what happens to them. We want to focus on strengths, resilience, and capacity for recovery, and offer realistic choices and support autonomy whenever possible. So with the BTQ, the individual retains control throughout the entire process. They can skip questions, they can decline to answer, and they can control the pacing. And this is a trauma-informed shift because we're going from mandated exposure to a supported choice. For the core principle, cultural, historical, and gender issues, SAMHSA tells us we need to recognize the impact of culture, identity, and lived experience. We must be aware of historical trauma, bias, discrimination, and systemic harm. And we want to deliver services in a way that is responsive, respectful, and equitable. So BTQ has a consistency and fairness built into it. It's a structured format, and it ensures same questions for everybody, which means reduced bias from staff interpretation. They're yes/no answers. There's consistent thresholds for trauma exposure. And the trauma-informed impact is that it creates a more equitable treatment across individuals and less reliance on subjective judgment. So this is just the bottom line. The trauma-informed network, and I'm sorry if you can't see that, promotes emotional safety through clear, structured, and predictable questions. It limits unnecessary detail to reduce the risk of re-traumatization. It shifts the focus to what happened rather than what's wrong, or what happened to you versus what's wrong with you. It normalizes trauma exposure within a respectful, non-judgmental process. It supports trust by creating consistency and transparency in screening. It provides a foundation for person-centered and trauma-informed planning. And it promotes choice and autonomy in how individuals engage and respond. So let's talk about how to administer the BTQ in a trauma-informed way. So we want to introduce the purpose clearly. We want to explain why we're asking instead of just walking up and saying, I have a few questions for you, and just dive right into it. We want to set the expectations. There's 10 questions. They're just yes and no. You don't have to provide us with any details. I'm going to ask you a few yes/no questions about experiences that can help us understand what supports might be helpful. We want to use neutral and supportive language. We stay calm and non-reactive. We want to avoid pressuring them to move to the next question or discussing their trauma. We want to use a non-judgmental tone, and we want to avoid reactivity, such as, oh my God, that's terrible. You must be devastated. We don't want to do any of that. We don't ask for details. This is not an interview. We're identifying exposure. We're not exploring the story at this point. So we don't want to probe, and we don't want to ask follow-up narrative questions. What we do want to do is watch for distress. So we want to look for withdrawal or agitation or just silence, so that if needed, we can pause, offer some grounding. Do you need a glass of water? Do you need a tissue? And then we also want to reassure control. We can slow down and stop if this feels like too much. We can pick it up another day, whatever that might be, to help reassure the client. Excuse me. We want to respond, not react. We don't want to overprocess. We don't want to try and treat in the moment. We just want to say, we want to acknowledge the disclosures, but we just want to say, I appreciate you letting me know. And then we want to close the process safely. We want to normalize the experience, just something like, you just sometimes when answering these types of questions, it can bring things up. This is a normal response, whatever that might look like. We want to reinforce next steps. So you'll be hearing from my peer in the next couple of days. We're going to do this, we're going to do that, just so that they know what's coming up next. That helps with that feeling of safety. And this helps us make sure you are connected to the right supports. Again, I want to stress that this is a mutual and person-centered process. What we don't want to do is say, tell me what happened. Why didn't you just move? Or showing shock or judgment, or pushing through distress. If you recognize distress, we don't want you to push through it. So how to use the BTQ responses to inform decision making. So it can help us identify the need for further screening. We ask the question, do we need to look a little bit deeper? So for example, if we see multiple exposures, we want to make a referral or screen if we have that capacity for PTSD symptoms. If we see trauma and substance use, we maybe want to make a referral or assess for co-occurring disorders. And if we're seeing high risk events on that screen, we want to maybe consider a safety assessment or a wellness recovery action plan. And then we ask ourselves, questions like, do we need to pay closer attention, slow things down, bring in more supports? And the BTQ kind of helps us answer these questions, in addition to the rest of your assessment, of course. So we always want to distinguish exposure from symptoms. Again, the BTQ is a history of exposure. So it doesn't tell us any current distress, it doesn't diagnose for us, and it doesn't give us any indication of functioning. So our decision at this point is, A, don't assume it's PTSD, but do refer and assess impact if indicated. The BTQ can help inform level of care and priority. So just some examples of patterns to look for is if you're seeing multiple or repeated trauma, we may want to increase clinical attention. If we see interpersonal violence, we want to anticipate a higher level of complexity. And if we're seeing those ACEs or early life trauma, there is potential long-term impact, and not just emotionally or behaviorally, but studies, as we know, indicate that physical and chronic illness are also, physical symptoms and chronic illness are also indicated in ACEs or early life trauma. So our decision here is to adjust the intensity of our services and just ask who needs more structure, more support, more flexibility, and the BTQ can help us do that. It also can help us guide referrals. So the responses can point to whether a person needs trauma-specific therapy, if they need substance use treatment services, if they could use peer support or recovery services, case management and stabilization supports. So the decision here is who needs what kind of support. It can help shape our engagement approach. So it can set while we're doing it, it can inform us the pace of services that we want to provide, a communication style and expectations. So for example, if we do see a positive trauma history, we want to emphasize predictability, trust, and again, flexibility. So with high trauma, we want to take a little bit slower of a pace with folks. If we're seeing distrust or avoidance, we want to keep calm, neutral, and be predictable, that sort of thing. So across systems, for courts, it can help us see, have more realistic expectations and graduated responses. For probation, it can help us decide supervision strategies that account for instability. For law enforcement, it can help us with de-escalation awareness. For case managers, we can see prioritizing stabilization, such as housing and basic needs. And for peers, it could show us if they need increased engagement and or trust building. Just some examples. The BTQ can and does support case planning, so you can integrate it into your treatment plans, reentry planning, court decisions, even field interactions, and again, focus on stabilization, safety, and appropriate referrals. So we have different roles. I saw who was attending today, but we all have the same goal, which is to understand behavior more accurately, respond more effectively, keep people engaged, and improve outcomes across systems. At this point, the BTQ helps you gather context and you're adjusting how you interact or respond, and then you're connecting to the right supports based on that. What not to do with the BTQ results. Don't assume PTSD. Don't label a person based on their trauma exposure alone. Don't skip further assessment. It's just a little tiny bit. And don't ignore the information. As you can see, it can be very important. So let's talk about some clinical and ethical considerations with administering the BTQ. First and foremost, we want to avoid re-traumatization. So again, we don't ask for details or narratives. We don't push for disclosure, but we do monitor for distress and respond appropriately. And this principle is do no harm during screening. We want to exhibit cultural humility and context because trauma is shaped by culture, identity, community, and historical experience. And different people may understand, describe, or minimize trauma differently. And if you have an example of this, I'd love for you to put it in the chat. And so staff should avoid imposing their own definition and interpretation too quickly, because trauma must be understood in this context in order for us to be able to plan and provide meaningful care. We want to respect choice and autonomy. Participation, at least for my program, is voluntary. Clients can skip or stop at any time, and we want to avoid coercion or pressure. We want the clients to remain in control. We always want to maintain appropriate boundaries. The BTQ is not therapy. We are not processing trauma during screening. So we want to stay in the role of just interviewer at this point. We are screening, not training. And if a boundary is being kind of wavy, coming in the other direction, we just acknowledge what they said, set a gentle boundary, and redirect. We want to make sure we have informed consent with clear purpose. I've said it before, but people should understand why it's being used. They should know how the information may be used, and screening should not feel misleading or hidden. So be clear about the purpose before before asking any sensitive questions. You might want to discuss confidentiality and information sharing, especially with folks who are a little more paranoid. We want to be honest about who will see the information. We want to clarify the limits of confidentiality if that's applicable. So, I could be subpoenaed by a court because I'm involved with people in the criminal legal system. So that's a limit of my confidentiality. We want to avoid collecting trauma information that will not be protected or used responsibly. It should be handled carefully and transparently. And that's my research side, sorry. And then definite role clarity. It's not a screening tool. It is a screening tool. It's not therapy. Stay in your role. Even if you're the supervising clinician, when you're administering the BTQ, you're just the BTQ screener. We're not doing trauma processing, diagnosing, or treatment planning because that may require a licensed clinician based on the results of that screen. So it's important to know the difference between screening, supporting, and treating. When you screen for trauma, you have a responsibility to follow up. It creates an obligation to respond appropriately. So if exposure has been identified, there should be a plan for either referral, further screening, what support you're going to provide, or a safety follow-up if that's necessary. Do not screen for trauma if there's no plan for what comes next. That's the worst thing you can do to a person with trauma. Maybe. I don't know if it's the worst, but it's pretty bad. A little caveat, you may come across some disclosures. So things such as child abuse concerns, elder abuse concerns, imminent safety concerns. So know your reporting laws, procedures, and your agency policy, because it may uncover some issues that may require action, unfortunately. We want to avoid overinterpretation. A high BTQ score does not necessarily mean PTSD, and a trauma history alone does not explain everything. So you should not make assumptions about the diagnosis, the risk, or the motivation based on this trauma screen alone. It gives us context, but it doesn't give us the whole story. Excuse me. Timing and readiness. Even a good screen can be poorly timed. So we want to avoid administering the BTQ when someone is maybe highly dysregulated, intoxicated, of course, in acute crisis, or medically unstable. And what we say in research is good screening also depends on good timing. And this is extremely important as well, secondary trauma and staff wellness. Repeated exposure to trauma disclosures can and does affect people. So your program and your supervision support should support extra supervision if necessary, consultation, debriefing, and discussion around boundaries. Trauma-informed systems must also support the workforce if you're truly trauma-informed. So now I'm going to share with you some of what our data shows us. We've been administering this tool since 2022, so we've got a good bit of data. So first and foremost, the data tells us that trauma exposure does not equal failure, but it does predict complexity. So in our population, higher BTQ scores, so 4 and above, saw clients with more missed appointments, more relapse, more crisis and housing instability, and more mental health diagnoses. And lower BTQ scores, 0 to 2, we saw stable engagement, faster completion, and fewer relapses. But the bottom line is trauma doesn't mean someone won't succeed. It just means they may need more support to get there. And the BTQ helps you identify that. So we see clients with really high trauma scores that struggle, but when they stay engaged, they still make progress. And I'm going to share one of our difficult clients with you if we have time. Complex, not difficult. That was unfair. The next thing our data told us is that engagement is the strongest predictor of outcomes, not trauma history alone. And I was kind of surprised by this, but it makes sense. So across all BTQ levels, consistent engagement equaled success. So even in, high trauma clients, they improved when they stayed connected, used peer support, and had structure. And we have had clients with significant trauma histories, but once they linked with peer support and they stayed engaged, they did actually stabilize and they made progress. This is also important. The behavior we see is often the impact of trauma, not resistance to the program. So high scoring BTQ clients in my data often had non-compliance. They showed missed court and other appointments. They displayed avoidance, and they had relapses tied to stress or triggers. And this can show up in other ways. So in court, we kind of see participants with overwhelm. They're just like frozen at the spot. They have a difficult time expressing themselves to the judges, or they can't answer, or they avoid. That can be an impact of trauma. With probation violations, for example, you may see dysregulation and instability. With law enforcement, you may see fear and really reactivity. Again, that could be a trauma response. And then with social services involvement, we might see family stress and trauma cycles, unfortunately. Our data told us it's not just the services we offer, it's how we deliver them. So our improved outcomes came as a result, and I'm beating a dead horse, but peer support, consistent case management, flexible engagement. This one is pretty big because I don't know if you guys have had this experience, but sometimes we have a hell of a time getting our clients to engage. But we try to stay as flexible as possible. We meet them where they're at. We're a mobile outreach unit, we call ourselves, because it's wherever you want to meet, however you want to meet, we will do it. If it means texting you through this meeting, let's do it that way. And by using a trauma-informed approach. So what we see in the data, higher trauma means more complex needs, but not less motivation necessarily. Engagement predicts success across all groups. Trauma often shows up as behavior and not disclosure. Again, remember, a lot of times people don't disclose unless they're actually asked. And trauma-informed approaches improve outcomes. So the bottom line is, excuse me, the BTQ doesn't just identify trauma, it helps us understand behavior and respond more effectively. So we're going to go through a couple of our cases. This is Kayla, and Kayla entered into our care with multiple behavioral health and legal stressors after multiple DWIs and inpatient treatment, and I believe her case manager is in the audience today. She was referred via the Buffalo Drug Treatment Court, and she was at that time balancing being new to court, parenting, work, and the court obligations and appointments. She faced barriers including insurance lapse, financial stress, legal pressure, and marijuana-related mood struggles. And her recovery was a little uneven with reported substance use setbacks, particularly around marijuana. So how the BTQ helped guide us? So it identified trauma that the client didn't initially recognize. So before completing the BTQ, Kayla actually, Amanda, introduced the idea to her. We're going to do this. This is how it looks. And she said, oh, I don't have any trauma. And Amanda was like, well, I have to do this. So let's just kind of go through and get it over with. Well, the questionnaire helped surface a high trauma score and identified exposure to a serious motor vehicle accident, a natural disaster, ACEs, an assault, a serious injury, family violence, and she also witnessed a serious injury or death. And it changed how we understood the case. Once it kind of showed that trauma exposure, we could kind of understand it through a different lens. If we didn't do the BTQ, we might never have known, because she didn't self-report anything in diagnoses or anything like that. So we wouldn't have known how to proceed other than like compliance with the court and obviously support. It helped guide her level of support. Through the trauma-informed case management, we added peer support and dual recovery therapy, which is part of our evidence-based model. It's a 12-week psychosocial educational series that the case managers provide to our clients if they want to. And the first session is great because it helps them understand the relationship, its timelines, and it helps them understand the relationships between their legal involvement, their mental health symptoms, and their substance use. So it helped us share our intervention focus, and as it progressed, care plans started emphasizing mental health stabilization, and Amanda worked with her on trigger identification, coping strategies, and time management, and we also helped her with support building. So again, high trauma exposure often means we need to focus not just on abstinence or compliance, but also on stress regulation and support needs. The BTQ helped explain why her progress was uneven. It helped frame that uneven progress within a trauma-informed understanding of instability and competing stressors instead of seeing it as setbacks or simply as a lack of effort. She had a lot of housing instability, missed appointments, relapses, court sanctions, but she also made meaningful progress with treatment once we kind of understood what was going on. So this is where Kayla ended up. She stayed engaged in treatment and recovery planning. She engaged in DRT and used it productively and gained insight into trauma she had not previously recognized. She worked toward reducing her substance use, especially marijuana, and has had consistent negative toxicology screens. She shows motivation for change, improved money management, and she got her driving license back. And she developed more self-awareness about that connection that I just discussed about with the DRT. And I'm happy to say she's progressed enough that she is now preparing for graduation from court and from Hope of Erie County. So it helped us see what was underneath her case, not just the stuff she kind of told us about. Now, just so you don't think life is all tinted rose-colored glasses, whatever they say, we're going to discuss Charles. And Charles's case is a little more complicated. Charles has an extensive trauma history, including sexual assault and repeated violence. He came to us with severe mental health and substance use complexity and chronic medical issues. He experienced housing instability, legal problems, and repeated crises and law enforcement involvement. He demonstrated distrust of providers, and he had fragmented engagement as a result of that. And we realized he needed more intensive trauma-informed and cross-system support. So BTQ's role in Charles's case, it helped us frame the case as one with significant trauma burden, not just mental health and legal instability, because if that's all we knew, that's what we would start working on. It helped to explain to us why there was that distrust and anger and avoidance, and also the really often repeated crises across systems. It gave the team a stronger reason to approach the case with a trauma-informed structure, persistence, and coordination, rather than relying only on compliance-based responses. And it reinforced the need for more intensive case management, crisis planning, housing advocacy, medication continuity, and cross-system collaboration. So what helped? So as I said, Charles required intensive case management. The team coordinated across multiple systems, including parole, law enforcement, crisis services, APS, housing resources, benefit supports, and behavioral health agencies. And this is Kyle's client. He's on the call as well, and he's a peer. Supports included motivational interviewing, crisis referrals, housing advocacy, SSI, HEAP assessment, anger management efforts, medication access help, and transportation problem solving. So the team kept working toward routines with Charles and stability and practical supports rather than depending on one service alone to solve everything. So while Charles is still a difficult, complex case, we do see signs of progress. And even in a very unstable case, there were still small but meaningful signs of progress. He showed some improvement in self-advocacy, which was big, including around getting his rides and making his appointments. He developed some new routines, including the use of planners and structure, and that gave him small gains in his self-management. He adopted a cat, which he calls Kitty, which became an important source of emotional support and stabilization for Charles. And he even had moments of gratitude and insight, even though the case remained highly challenging overall. And if you knew Charles, you'd be surprised that he had moments of insight and gratitude. So where are we today? He remains at high risk for decompensation, housing loss, and legal consequences. The case continued to involve cycles of anger, disengagement, distrust, and crisis, even with strong support. And I want to stress this, the trauma-informed perspective helped the team focus on containment, coordination, and realistic support rather than assuming the person was simply refusing help. So the tool is not only helpful for all the reasons I already listed, it's really helpful specifically for the team in framing the case in a different way. And this case shows trauma-informed care is especially important in high acuity, high instability situations where simple compliance approaches are simply not enough. I mean, just sending them to substance use treatment wouldn't have taken care of all the other complexities in his life. And that's all I have for now. So I want to ask, do you want to ask questions, or should we go to discussion questions? Should we talk to the Hope team and see what their thoughts are?
One question that came in as you were talking, Dede, there's a question that came in. What age group can the BTQ be used for, or what age is it validated for?
18 and above. Yeah, it's for adults, unfortunately. Okay,
the only question right now, but please take a moment if you have questions to put them in the chat, and we can make sure that Dede discusses them.
So before we go to discussion questions, Matt Joyner, do you want to talk about your pros and cons? Sure, no problem. All right, he's going to put it in the message, Kathleen. Thank you. While he's typing, I'm going to tell you.
I just unmuted him.
Oh,
so
good.
He can talk if he wants.
Thanks, Amy. I appreciate it. So with the BTQ, we've learned quite a bit, specifically myself working with COSIP clients in the community. The BTQ itself has really kind of taught me how to approach not only helping individuals in the community, but learning more about what their needs are. Some of the pros around the BTQ itself, for myself, when asking the questions, it's, we practice, and the more practice that I had with this tool, the better I got at asking the questions, not so much word for word, but trying to articulate and ask the questions to the individual so they were better understanding of what was being asked. This wasn't something that I wanted to use to say, this is some type of punishment, or, we're trying to relive other trauma. We're trying to bring up, some past things that may or may not, affect you in throughout your day to day. But the pros itself really kind of helped shape my relationship with the individuals that I'm helping in the community. Some of the cons that I saw specifically with clients with serious mental health diagnosis, bipolar, schizophrenia, it was very difficult. It's still kind of challenging for me to get a honest response from individuals. We know that majority of the people that we're helping in the community have suffered from some type of trauma. And when people are trying to explain to me that they quote unquote don't have any, it's kind of hard to push that question without, having a clinical license or being clinically motivated to, ask those questions in that clinical environment. So there's a lot of times where I really have to kind of take a step back with that individual, come back to the team, bring this question up, and how to address it in a different way with the clinical supervisor, Carrie, that we have on our team. She's been extremely helpful, especially with me and the clients that I help in the community, because the majority of the clients that are on my caseload, they're very challenging, and a lot of times it's like I said, it's very difficult to get them to be honest, because being in the community, asking these questions, they're already stressed out, they're homeless, they're actively using. So there's some times where it's very difficult to get an honest answer. But another flip side on that, a pro of that, is that, as time goes on and as Dede has presented, we can revisit some of that stuff as the relationship continues to grow. Some of this stuff really kind of starts to come out as time goes on. I mean, it's not something that, is is discussed within a day or two, but as months go on, that's a nice thing about our program too, is that we can maintain and keep people on our caseloads for some portion of time to really kind of get to know them and get to the grassroots of what they want to accomplish. So those are just a couple examples that I wanted to shoot out to everybody. And, if you guys have any questions for us and our team, we're by all means more than happy to answer whatever you need.
Thank you, Matt. And I believe, some peers from my program in the audience. So Scott, Kyle, and I believe Lynn, if you would like to contribute with your experience from a peer perspective. Let Amy know in the chat if you do, and she'll unmute you. While we wait, I'm going to give you some discussion questions, and if you feel compelled, you can answer one, you can answer all of them, you can answer none, but I'd like to spark a little discussion and get some feedback from you. So the questions are, what stood out most for you to you from today's presentation? How might the BTQ help us understand behavior differently? What are the ethical risks of trauma screening if it's done poorly? How often do you think trauma is present in the populations you work with, even when it's not directly exposed? Exposed. What do you see as the biggest value of using the BTQ in your setting? Did my peers check it out?
Kyle M said, I can go for a minute. And then Linda also said she can talk a little bit about what it looks like from a peer view.
Great. Love it.
Sure, I'll talk about my case client that we discussed, Chuck. He was a very challenging one. For me, I like how the BTQ just kind of identifies the issues without getting too much into it, because now that I kind of know what's going on with him, and he was involved with so many different services. Oh, I'm sorry.
That's Daisy.
I don't know if it's going to stop. I'm sorry, I'll have to choose something.
Is Lynn unmuted? Maybe she can go while he's wrangling a puppy. Oh, someone's at his door.
Can you guys hear me?
Yes. Thank you.
Hi, I'm Lynn, and I am a peer caseworker here at Hope of Erie County. And I feel like the BTQ is extremely helpful for just allowing the person to understand themselves that they did have trauma. I think that is usually one of the most shocking things, is that, somebody can score really high and not even know or have any, awareness that they were in fact traumatized. And I think that when we can look through a trauma-informed lens, especially when, we're talking to people who have been traumatized, it's just really, really important. It's important work to be able to open up these doors that could allow them to reach a higher potential, in my opinion and in my experience. I think that it just helps to have that autonomy too, like to feel like they're heard. And yeah, that's pretty much how I feel about the BTQ.
Thank you, Lynn.
Yeah, of course.
And then I think I have some case managers in here today, Amanda and or Carrie. Do you want to discuss your experiences, even though I stole Amanda's case? Because that's Amy's favorite.
Carrie said sure. So Amy, if you want to unmute her.
Carrie, if you want to just unmute, there you go.
Oh, okay, here we go. Can you hear me?
Yes.
Hi. I was just typing as Lynn was speaking. I just wanted to also point out just how helpful, and it kind of just piggybacks what she just said, but how helpful it really is for certain people to recognize that what they've actually gone through is considered trauma for them. And we see that so often, like just the way that certain people sort of describe their experiences or say yes to these things, and then like have that moment where they say, wow, that really is trauma, and they've never really thought it to be traumatic prior to. So I think that that's just really a huge huge piece that I've seen as a case manager using this tool. I mean, it's really been revolutionary. And obviously, the other benefit that goes unnoticed is just making sure that if there is a need to have additional services, that we've now detected that need to refer or discuss if they're ready for additional support at this point. But I think it's been, since we've implemented it, such a valuable tool for us. Sorry, we've got a noisy one over here too.
We're dog lovers at Hope, as you can.
My dog agrees. She likes
Yeah.
the BTQ.
Thank you, Carrie.
You're
And thank you, everyone.
Amanda said she can also go, so if we have, I think we have another minute or two, so maybe Amanda.
And Amanda, if you can just unmute yourself, you're all set. I see you're unmuted, but we can't hear you.
Uh-oh, okay. Going once, going twice. All right. Thank you
What?
anyway, Amanda.
Yep. Oh, she just said I tried, but one question that did come in, can you remind what events on the BTQ there is trauma exposure that can be a red flag if one of your clinicians was looking at the form?
What event or which domain? Which question?
This word is what events on the BTQ?
Carrie, do you want to take that one?
Can you repeat that question? Sorry.
Sorry, guys.
What events on the BTQ there are trauma exposure that can be a red flag if one of your clinicians was looking at the form? And they did clarify to say questions, so I don't know if that helps.
Question. Okay. Can you remind what event on the BTQ there's trauma?
So I'll kind of get it moving. ACEs is always an indicator for us. We're always paying attention to the ACEs, unwanted sexual contact for sure. Some of those violence questions and watching friends and loved ones, we work with people who use drugs. So we have a lot of people that have watched one or several of their friends literally die in front of them. So just stuff like that. And so in addition to the rest of our screening, if they've never gotten treatment for it or done grief counseling or anything like that, those are always definitely red flags for us. I hope that answers that. But it's also really in context. Like, so if they're indicating that, yes, they were injured or, those last two columns, that is really the indicator that we need to pay attention to that. That really should. So if they just say, yes, I was in the military and did this, and this, but no, it didn't really affect me, then it's not really so much of a red flag. But the more we see of the injury, that's when we really start to pay attention.
Looks like one last question that came in. What are the advantages of the BTQ versus using just ACEs? Additional domains? Question mark.
Yeah, so for our clients in particular, because they're involved in the criminal legal system and they use substances, we know that they have potential for lots of re-traumatization. So they likely or may have ACEs, but then there's all the other stuff that comes afterward. Or they may not have ACEs, but they do have this additional because of their use or their legal involvement. They've been in prison, they've been in jail. That can be traumatizing for people. So that kind of thing. So ACEs is great, but in my opinion, for my population, it's just a starting point.
All right. Just looking at the time, just wanted to say thank you so much, Dede and team. Great presentation information. And thank you, Amy, for coordinating. And thanks everybody for participating today. A few things Amy is posting into the chat. There is a link to our evaluation, so we'd ask you just to take a brief moment to complete that for us. She also has posted the link for our Training Collaborative website, and our upcoming session in July is already posted, so please take a moment and register for that. Also a reminder that tomorrow is the Anti-Stigma Facebook Live, which is also about trauma, so great tie-in for the information today as well. As always, if you're interested in being a presenter, please let Amy know. If you have ideas for topics you'd like to know more about, let us know that as well. And thanks again, Dede, for a great presentation.
Thank you. And I do want to thank the Erie County Department of Mental Health for always being a valued partner to Primary Care Research Institute and my programs in particular. So thank you very much, guys.